welcome to the August Norwich Institute of Healthy Aging lunchtime seminar. My name's Andy Jones. I'm Professor of Public Health in Norwich Medical School, and I'm chairing the session today. We've got 3 speakers, so it's quite a tight timetable. First 2 speakers, we've got 15-minute talks with kind of around about 7 minutes for questions, and then in the members section we've got Jeremy Turner talking about the Clinical Research Network. In terms of questions, as usual, there's the 2 routes. Either if you've got a question, you can put it in the chat and we'll do our best to pick them up at the end of each talk, or also you could put your hand up and then actually say your question. So without further ado, I think we'll make a start. So first we have Professor Ailsa Welch, who's a Professor of Nutritional Epidemiology at Norwich Medical School. Ailsa is going to be talking about her work on the links between diet quality and mental well-being in Norfolk children. Unfortunately, Ailsa's got a technical problem and her webcam's not working. But we all know how good Ailsa looks, so that's fine. But hopefully Ailsa's slides will share all right. So what I'm going to do is pass over to you, Ailsa, and look forward to your presentation.
So I'm hoping this is sharing okay. Can everybody, does that look as though it's sharing the right version? As we heard earlier.
That's perfect.
Oh, fantastic. So at least that's worked. Thanks very much. So, well, thanks very much for inviting me to talk today, and which I think is a very important subject about the links between diet quality and mental well-being in children. And specifically, I'm talking about some work we did in Norfolk. And this was a collaboration between Norfolk County Council, the UEA Health and Social Care Partners, and UEA itself. So, this work that I'm going to talk about was put together by the Nutrition and Childhood Wellbeing Group of the UEA Health and Social Care Partners. And we've just recently had our paper accepted by BMJ Nutrition, Prevention and Health, which talks about the associations between school children's fruit and vegetable consumption and meal choices and their mental well-being. And the people involved in this, and there will be a press release coming out in about 3 weeks or so about this. The BMJ have chosen it for a press release. So Richard Hayhoe did the work. He did the lion's share of all the analysis. He was at UEA and now Anglia Ruskin. In the County Council, we had Boyka Reckel, Claire Gummerson and Louise Smith as part of the group. And then from UEA, Alan Clark and myself. So why do we care about mental well-being in children, and why nutrition? Well, what we know about brain development and cognition is that it develops before school, actually from birth through to preschool, teens and adulthood. We also know that nutrition provides building blocks for brain growth and development, including vitamins and minerals and long-chain fatty acids. And we know that deficiencies of magnesium, folate and zinc are involved in depression symptoms in adults. Must apologise, I got a blue square there where there was a very nice photograph of some school children, but that seems to have disappeared in the way of putting this together. But also there's some work that's shown that high fat, high sugar diets impact on proteins that are critical to brain development. An example of this is a brain neurotrophic factor. And also nutrients have mechanisms to impact on mental well-being, and particularly brain signalling molecules. And even more of an issue, I think, in terms of why we want to address mental well-being in children is that half of mental health disorders develop before the age of 14. But also before we did this study, there's actually very limited previous research on diet quality and childhood mental well-being. And diet is one factor that we could modify. Many other factors involved with poor mental well-being in children are much harder to change. So this survey was done in 2017. And this slide shows the details and the methods. And we surveyed 50 schools across Norfolk, and you can see from the map that there is a wide diversity of schools taking part, particularly including schools from areas of deprivation as well. So I'm presenting the data today for just over 7,500 secondary school children and just over 1,200 primary school children, although actually the data itself, the main results I'm going to show from the secondary school children. And the main measurement of mental wellbeing was the Warwick Edinburgh Mental Wellbeing Scale in the secondary school children and the Sterling Children's Wellbeing Scale in the primary. Both these scores are validated against well-established factors that impact on mental wellbeing. And the study was commissioned by Norfolk County Council Public Health and Norfolk Safeguarding Children's Board. So what do we measure in terms of nutrition? Well, we looked at breakfast type and whether children had a breakfast or not, whether they had a conventional type, whether they were just having an energy drink for breakfast. And I'll talk in more detail about that when I show you the results. The same in terms of school meals, whether the children didn't have a school meal, whether they had a packed lunch or a school lunch. We looked at free school meal status, fruit and vegetable intake, number of portions a day, also alcohol consumption and weight satisfaction. So in terms of the factors that we measured that are other factors that were measured known to influence mental well-being, there were a number of demographic factors such as age, sex, ethnicity, and deprivation, area of deprivation. We looked at, in terms of health, disability, long-term illness, smoking or vaping habits and drug use. Particularly useful and interesting in children at this age is living at home situation, whether they had their own bedroom or bed, and parental smoking status. And then even more relevant are adverse experiences. So whether children feel safe at school or home, whether they've been bullied, whether they bully others, and whether they witnessed arguing or violence at home. So we used a statistical technique called multivariable regression, and I described this slightly more for people who are not really involved in statistics, but we wanted to understand the links between nutrition and mental well-being, but we also wanted to understand how this related to the demographic, health and adverse experiences variables that I just talked about. So this is the first slide in relation to the results, and you can see that the mental well-being score ranges between 14 and 70, and in the children the average score was about 46. So that means that they weren't exceedingly high on well-being, but there were some that were also low. When we look at breakfast type, you can see this is the type of breakfast that children were consuming. So a conventional breakfast we coded as the type of breakfast that a usual breakfast that included a full range of types of foods. And then, so that's about 70% of those, but actually really concerning is that 15% of children were having nothing. Another 7% were either having a drink only or 1.2% only had an energy drink. So altogether, there's over a fifth of children going to school without any food per se at all each day. So when it comes to fruits and vegetables, which we know I've mentioned earlier, some of the nutrients are protective that come with fruits and vegetables are likely to be protective for mental well-being. Again, this shows some rather worrying statistics. Only a quarter of children had 5 a day or more, and actually at least 1 in 10 had no fruits and vegetables. And then between that, we've got those children with 1 to 2 a day, or about 40% with 3 to 4. So basically, they're not doing too well on that front. When it comes to lunch, we compared the data that you're about to see shortly in relation to a packed lunch sent from home. And you can see again, about a third of children had a school lunch. And then, but again, very concerningly, 11% had none. So when they, nothing at all for lunch. So in terms of portions of fruits and vegetables per day, mental well-being, these are results from the large analysis done with all the factors. You can see the categories that we looked at. You can see whether they had no vegetables or fruits and going up to 5 or more. So these differences maybe don't look terribly big on this graph because you can see the confidence intervals. It doesn't look much, but you can see the difference between 0 and 5 portions a day was 3.7 units. And this was statistically significant, as you can see by the confidence intervals. So again, you might think, well, maybe this isn't too much, but actually there was a 15% difference between the children who had none in their wellbeing score and the children who had 5 or more. Likewise, looking at breakfast, again, we have the conventional breakfast as the reference category, and you can see the different types of breakfast that children were consuming. So whether they had a non-energy drink or an energy drink or nothing. And the difference across these categories, again, for energy drink was minus 3.4 units, and nothing was a minus 2.7. And these equate to differences of 18% and 15.6% across compared to the conventional breakfast. So there's something not really very good going on here. So to summarize, the primary school the findings were quite similar in many ways, but not quite as startling as those for the secondary school children. 3/4 of the children were not achieving 5 a day in terms of fruits and vegetables. And the scale of the effects I've just been talking about on well-being, so either positive effects of 3.7 units, which is a 15% difference, compare with the factors that we know do cause harm in terms of well-being. So comparing with violence or arguing at home every day or almost every day, that in the analysis was minus 3 units, and feeling unsafe at school was minus 7.2. But basically these findings are in relation to, the data on children's diet was still significant in the models despite having adjusted for everything. So to me, and if you translate this into average class of 30 for children, in secondary school children, at least 4 of them will have nothing to eat before starting classes in the morning, and a further 3 will have nothing to eat or drink before starting classes in the afternoon. So it seems to me these findings are actually of real concern. So caveats, this is cross-sectional data, and we need final proof from randomized controlled trials. There are much more precise methods for measuring nutrition available, and I've spent large parts of my career either developing those or working with that. But what we know is the relationships with the known factors were as expected. We found negative associations with being bullied and with arguing at home and so on. And as you would expect with this type of, as has already been established, and there was a wide uptake of the survey, and it was a representative sample. So the point now is, what are we going to do about this? Public health messages and actions, what should we do? And basically, we need to keep promoting the benefits of 5 a day and healthy meal choices. And I think what would be new for public health messages, despite the caveats and the fact that this is, not a definitive study, is that we could be highlighting the importance of fruits and vegetables for mental well-being in children. But we also need to know why some children are not having breakfast or lunch or consuming energy drinks only. Is this an economic reason? Is it social, cultural, or knowledge-based? Is it that teens just think actually it's just not cool to have this stuff, that actually it's cooler to go to work with an energy drink or not? And is that something that could be changed? But we also know that provision and access to fruit and vegetables is limited in areas of deprivation. And we did some earlier work understanding the effectiveness of a fruit and vegetable ban that did actually improve access in the past. But also, I think we need to encourage greater provision of breakfast clubs and ensure that all those eligible for free school meals use them. And actually meals need to be including at least 2 or more portions of fruits and vegetables to address that inequity in fruit and vegetable consumption, particularly in children who are living in a disadvantaged area. So final slide. These findings were from data collected in 2017. I think with the advent of COVID, the situation is likely very much worse now. And certainly once we end up with furlough, it ends and so on, this is going to have a big impact on parents' ability to look after their children. I suppose there's better news in many ways, because recent Public Health England priorities include mental health and nutrition, and the new United Kingdom Health Security Agency and the Office for Health Promotion are going to lead efforts to improve and level up public's health. And local health priorities in Norfolk are also include mental health and obesity. But overall, what we need is to be supplying our children good quality nutrition, and it needs to be available to all the children, because we want to optimize mental well-being and empower children to fulfill their full potential. Because we've seen that actually restrictions on this are going to lead to big issues for children. And we have a perfectly good dietary guidelines in the UK, the Eat Well Guide, which is a plate that shows how much fruits and vegetables, cereal foods, and the other types of foods we need. But large numbers of the children, this third of the plate is actually missing for a large proportion of the children I've shown you today. And probably these other foods are kind of filling this in because, economically, it's very hard for parents sometimes to actually afford this type of food when they're on a very tight budget. So thanks very much to the participating schools, Norfolk County Council and UEA colleagues for their contributions. And I'd like to thank you very much for listening, but I would also like to then discuss these findings and see what people feel, because I feel this really does need to be translated into some action. So I'm going to stop my sharing now and hopefully
brilliant,
be able to discuss this with folks who are interested.
Thanks for that, Ailsa. Thanks for perfect timing as well. So just a reminder for anybody that wishes to ask a question that this session is being recorded and you will become a YouTube star. So just to keep that in mind.
I didn't know that.
Yeah, there you go, you see. You can have millions of followers soon, Ailsa. So I don't have anything in the chat. I don't see any hands up. Can I take Chair's option to ask the first question? It's the obvious one, I guess, really, around residual confounding and the fact that it's so difficult to tease out direct effects of diet from the basic living conditions of these children. And have you got any thoughts on that and how that may have affected your findings, Ailsa?
Yes, I mean, it's a good point, Andy, and we did what we could to try and address confounders, as I mentioned, with all those factors. I didn't describe all the ones that we included there in the paper, but you can never necessarily address everything, which is why ideally we want some kind of intervention study that actually can test this. That's going to be much better. But nevertheless, we were still, residual confounding or not, we're still finding positive and negative associations that were significant for all the factors that we do know impact on childhood mental well-being. And those are pretty obvious. If you're living at home with parents who are arguing all this violence every day, you're going to be pretty affected. So it was interesting that despite having put all those factors in the model, we still came out with something for nutrition. But we also know in many ways that fruits and vegetables are probably an indicator of the ability to afford them, so they're actually quite a useful marker, but it also means we may be able to address those more readily, by actions, particularly in schools.
Yeah, okay, that's great, thank you. So we've got a couple in the chat now. The first is, I don't know who this is, DAQ09EYU. I'm not sure who that is, but somebody's asked, are there any projects to address the problem of poor diet? So really moving on to interventions.
There are some, and I don't know if my public health colleagues are here. I actually I can see Louise's name there, and she may be able to talk more on the public health area if she wishes. But there are some, but I think, and there's, there are quite a few initiatives, but I guess they're not at complete government level in terms of actually doing something nationally. And it feels to me there needs to be a little more. Okay. Does anybody want to add to that?
Well, Louise has switched her camera on. So
yeah, thanks, Louise. Yeah, good to hear from you.
Hi, everybody. Is my microphone working?
Yeah.
Yes.
Hi, and thanks, Ailsa, for presenting that. I'm really pleased I was able to join you and hear the presentation. Projects to address the problem of poor diet. There are national campaigns and comms and marketing. You included some of the graphics, for example, in your presentation. There is work with other services. So, for example, our health visitor service. I think I'm generally of the view that we overemphasize the value of exercise and underemphasize the value of diet when we're considering and talking about public health policy on obesity. And often when I look around, I think, and I think this would be true for Norfolk, we're far more developed in terms of our strategies and interventions and projects on on encouraging physical exercise, and totally recognize it has other benefits as well as obesity or healthy weight. But I think the whole food narrative around the impact of diet on health is an area where I think there's a lot of room for more work to be done.
Yes, and I would actually add that I think there's much less emphasis on diet quality, really. There's a big emphasis on children losing weight and maintaining weight, but there's much less on positive eating, diet quality, and ensuring children, there's a lot about avoiding fat and sugar, but less information and fewer initiatives about actually improving the quality of what children eat in general. It doesn't all have to be about fruits and vegetables. And once you've got the quality better, people they're less likely to eat diets very high in fat and sugar, it seems to me. But there isn't that sort of governmental initiative that I can see at the moment, anyway.
Yeah. So. Okay, thanks. And the mystery person was Stephanie Howard. So hi there. Thanks for that question, Stephanie.
Thanks, Stephanie.
Okay. Rose has asked. It's about sort of behaviours clustering together, really, and missing breakfast and lunch, and were they the same kids that missed both?
Yes, and that's a very good question, Rose. And I was thinking about that yesterday, and actually we didn't look at that, and I think we may well look at that further if we have the opportunity.
That would be an interesting one, because it would help you also possibly tease out some of the causality, wouldn't it, to understand if there was a marginal additive effect of missing both. That may help tease out causal pathways a little bit.
Yes, and I think it would then help prioritise the children who really need, the families and the children, and areas where there need to be some very focused interventions. So yes, I think that's a very good point.
Yeah. So Anne-Marie's got her hand up.
Yeah, thanks, Andy. And thanks, Ailsa, for a really nice presentation. I just wanted your view on, we always consider fruits and vegetables together, but there's lots of really kind of strong analysis coming out now from consortiums like the Global Burden of Disease, which are kind of showing that fruits, when you take years of life lost or disability adjusted life years, it seems to be that fruits are more bioactive and have a greater impact on health. I don't suppose you had the capacity to distinguish between the two in your analysis because you asked the one question, but just to get your thoughts on whether you think we should be thinking of fruits and vegetables as separate entities going forward.
Yes, Anne-Marie, and that's another good point. Yes, we didn't have that, but actually my preference would be for increasing vegetables rather than focusing on fruits. And I think fruits are great, but I feel that there are many more wide-ranging compounds and varieties that are useful to eat, and they can be in more situations. Fruit's very handy for children. There's no way we should not encourage them to eat those, but I think the vegetable range, there's lots of bioactives, sulforaphanes and fiber and magnesium and a number of other nutrients that are really highly important in vegetables that you don't get the range of them in the fruits so much.
Yeah. I mean, just one. I don't think. I mean, Stephanie's made the point about which I agree, that we tend to gravitate towards physical activity. I'd use the term physical activity rather than exercise, but because it's easier to measure, which I think is definitely something that's true. Just a final from me, Ailsa. You mentioned clinical trials needed, but I wonder how easy clinical trials are going to be to undertake, given the barriers of the delivery of healthy meals at the family level in these sort of contexts. Is it really going to be possible to do clinical trials? No,
I mean, I guess perhaps that's the wrong term, really. I mean, there's no point trying to do a clinical trial. What you want is a focused intervention to see the difference, and that could be area interventions, and then comparing with areas. When we talked about this a long time ago in terms of public health, because you can't, in a way, this you want to be able to sort of measure the effects of an intervention and the change. In clinical trials are generally much more designed for drugs and so on, but you can actually do interventions that are stepwise and monitor areas, so then include people after that. So I think, or areas after that, so centres after that. So I think that will be the type of study or intervention you need to do. But clearly you need big numbers if you're going to do it like that, because you don't always have you can't necessarily capture all the kind of precision that you need to really get the definitive answers. So there's a bit of a, a difficult one, but certainly I think more thought needs to be given to designing those types of interventions for public health as well.
So I think there's just a danger, isn't there, of snuffing out promising interventions with a clinical trial, where the trial just basically is the death of the intervention, when actually something's rather good, but it just doesn't work in these sort of complex environments. That's a real challenge.
Yes, and I agree. And also just trying to hard to reach populations as well is very difficult. You know,
yeah,
it's actually the most complicated thing to do. So actually area interventions, say like they did in Finland or somewhere where, you intervene in the whole country, I think would be useful. Anyway, I'll stop talking now because I know you've got to get on to the next one.
That's right, it's perfect timing. Thanks very much for that, Ailsa. That's a really interesting presentation and stimulated some interesting discussion. So let's move on to our second presenter, Dr. Matthew Pontifex from Norwich Medical School. And he's going to be talking about gene-environmental interactions of apogenotype in the context of cognitive health. So over to you, Matthew.
Thank you very much. My name's Matthew Pontifex. I'm a researcher here at the University of East Anglia. It's my pleasure to be here today. I'd like to thank Anne-Marie and NIHA for inviting me to give this presentation. So I'm going to talk to you, as mentioned, about gene-environment interactions in the context of cognitive health, but I'll be focusing particularly on the ApoE genotype, its interaction with biological sex, and also the polyunsaturated fatty acid DHA. So let's begin with an overview of Alzheimer's disease. So Alzheimer's disease comes under this umbrella term of dementias, including frontotemporal dementia, vascular dementia, to name a few. And of these dementias, Alzheimer's disease represents or contributes to roughly 50 to 70% of all cases. It's an irreversible progressive brain disorder, and it actually takes years and even decades to actually manifest. The disease is associated with the buildup of amyloid plaque and tau tangles, and it's characterized by the loss of neurons and also the connections between neurons, known as synapses, leading to brain atrophy. And we can see a severe case of Alzheimer's disease on the right-hand side compared to a healthy brain on the left. So the disease leads to progressive cognitive decline, and therefore it's a particularly debilitating disease and has quite a heavy impact both socially and economically. Over the last decade, we've actually seen over a doubling of cases from 20 to 50 million, and to this day there's still no effective cure. So we're going to continue on a similar trajectory, and it's expected that we'll see a tripling of cases by 2050. But I think this model is really interesting because it shows that if we actually delay onset by as little as 2 to 5 years, we could see a reduction in incidence by roughly 20 to 35%. So therefore, prevention can indeed have a considerable impact against incidence. So there's many contributing factors to Alzheimer's disease. And the ones today I'm going to talk about, I want to just specifically note that I'm talking about late onset Alzheimer's disease, because familial or early onset Alzheimer's disease is particularly related to this genetic susceptibility. However, for late onset Alzheimer's disease, it's actually much more complex, and it's sort of an interaction between this genetic susceptibility and the interaction with your environmental and circumstantial factors that you're exposed to throughout your entire life course that overall decides whether you're going to progress to an Alzheimer's disease or more of a healthy aging profile. So some of these environmental factors have been identified through various cohorts and the combination of these studies into large meta-analyses. And some of these factors include diet, smoking status, or whether we're obtaining enough sleep. So in terms of diet, today I'm going to focus predominantly on docosahexaenoic acid, which is a polyunsaturated fatty acid found in oily fish. But let's first talk about the ApoE genotype, which is a significant risk factor in late onset Alzheimer's disease. So ApoE is located on chromosome 19 and encodes a 299 amino acid protein, referred to as apolipoprotein A. As the name suggests, it associates with lipoproteins and therefore is involved in the transport and metabolism of cholesterol and lipids around the body, but also within the brain. And therefore it's strongly associated with lipid homeostasis. Genome-wide association studies have confirmed that this ApoE4 variant of the gene, so first of all, sorry, I'll just mention there's 3 different variants, and we get one from our mothers and one from our fathers, and they come in ApoE2, ApoE3, and ApoE4. And basically, the genome-wide association studies have identified that the ApoE4 genotype is particularly associated, is actually the most common genetic risk factor for the development of late onset Alzheimer's disease. And as we can see, compared to the general population, ApoE4 is considerably increased in the Alzheimer's disease population. Similarly, the risk of developing the disease increases as we obtain ApoE4 genotypes, and the age in which onset occurs is similarly reduced. Now, the reason for this is because it's actually similarly complex, because the ApoE4 is pleiotropic and affects many different systems around the body. And having an ApoE4 causes both a gain of toxic functions and also loss of the normal physiological functions. Some of these are increased or decreased amyloid beta clearance and increased aggregation, and also reduced lipid and cholesterol transport. So how does ApoE, or how is ApoE influenced by environmental factors? So interestingly, less than half of these heterozygous ApoE4 carriers will actually go on to develop Alzheimer's disease. So what could be a reason for this? And I think this is nicely shown in this publication, which is based on cardiovascular risk factors, aging and dementia study, in which we see that ApoE4 carriers are actually particularly susceptible to some of these environmental or behavioral choices, such as physical activity, polyunsaturated fatty acid intake, and saturated fatty acid intake. And therefore, it shows how lifestyle strategies may be particularly beneficial to these ApoE4 carriers. So one such that I mentioned was polyunsaturated fatty acids, and I'm going to talk today about DHA, or docosahexaenoic acid, which is a 22 carbon structure. It's a lipid and is a polyunsaturated fatty acid, as it has multiple double bonds, and it represents an omega-3 fatty acid, as it has the first double bond is found on the third carbon on the omega side of the chain. Now, we can find DHA in various sources, but it's particularly marine oily fish, such as herring, mackerel, salmon, to name a few. And it's considered essential, although it can actually be synthesized from its precursor molecule, alpha-linoleic acid. However, it's done so at such a small conversion rate that it's actually recommended that we take 450 milligrams of EPA and DHA per day. So in the brain, DHA is particularly enriched, particularly in the cerebral cortex, which may indicate that it's important for brain function. Indeed, in the neuron membranes, DHA represents 60% of all polyunsaturated fatty acids, and it's critical for neurogenesis and nerve cell structure and function. And this really scary diagram sort of indicates all the pathways that DHA is associated with in the brain, but the take-home message is that it's involved with reduction in oxidative stress, increase in synaptic function, and neuroprotection. Sorry. So what's the interaction with ApoE and DHA? So this has been identified through carbon tracer studies. So the first one is in rodent studies, and we see, so when we attach an isotope of carbon to a DHA molecule, we can follow the life of the DHA molecule, and we can see that in these rodents, E4 carriers actually had reduced uptake of DHA into the brain. Similarly, in this human study, we find that the half-life of DHA around the whole body is reduced in E4 carriers, suggesting greater beta oxidation. So therefore, we can say that DHA potentially, the uptake of DHA and the metabolism of DHA is modulated by the ApoE genotype, with ApoE4 having a detrimental effect. The final factor I would like to talk about is the influence of sex, so male and females. So females seem to be disproportionately affected by Alzheimer's disease. And actually, when we looked into this in a review that we published back in 2018, we found that in terms of ApoE4 carrier, we found the same trend with females particularly affected compared to to male individuals carrying the E4. And one that took our particular interest was this study by New et al., which was a large meta-analysis, which identified that ApoE4 females between the age of 65 and 75 years were at particularly high risk of developing the disease. Given that the disease takes decades to manifest, we and others have hypothesized that menopause could be a trigger given the age at which we see the clinical manifestation. If so, then this would represent an interesting population subgroup who could particularly benefit from some kind of therapeutic intervention. So some of our own studies looking into this include, this is a preliminary study that we conducted using data obtained from the CAN study. So again, I want to stress it's preliminary and there was quite small N numbers in this study. But the CAN study was a randomized controlled trial looking at the effects of polyunsaturated fatty acids and flavonols. But we took the baseline data and looked at the effects of hormone replacement therapy. And we found in ApoE4 females receiving HRT, there was a trend towards an increase in two of the scores, episodic memory and picture recognition tasks. Similarly, in the MRI data, we found that cortex volumes were slightly increased in the ApoE4 females receiving HRT. And to tie this together with the DHA, a rodent study conducted in 2019 by our lab group found that females had reduced levels of DHA in the brain at 18 months compared to 2 months. And this wasn't seen in the ApoE4 males. So to look at this in some more detail, we set up a novel study where we induced menopause through what's called a VCD injection, which is a menopause mimic, at 8 months of age in ApoE3 and ApoE4 animals. And then we performed a battery of behavioral tests at endpoint to determine whether they had any cognitive deficits. And we also did further molecular analysis to determine some of the effects that could explain the drop in cognition. We also supplemented a subgroup of these animals with high levels of DHA, so the human equivalent dose of 2 grams per day, to see if we could ameliorate some of these issues. So from a cognitive perspective, we found that the ApoE genotype specifically affected spatial memory impairment. However, when we looked at recognition memory, we found that this was affected by both the VCD and genotype interaction. So this shows that the ApoE4 female mice who received the menopause mimic were unable to identify the difference between a novel and a familiar object. And recognition memory is associated with parahippocampal regions of the temporal lobe, including entorhinal and perirhinal cortex. And interestingly, other studies have indicated that these areas of the brain are particularly sensitive to estrogen loss. So looking at them at a molecular perspective to see what's going on in the brain, we looked at levels of DHA in the brain, and we found that actually the menopause mimic reduced levels of DHA in the brain in both ApoE3 and E4 animals. Some of the transporters associated with getting DHA into the brain were similarly reduced, but both in a VCD and a genotype dependent manner. So these transporters are ACSL6 and fatty acid transporter protein 4. So to follow this up, we looked at the influence on synaptic plasticity related pathways. So synaptic plasticity is the ability of the synapses to strengthen and weaken over time. And it's the neurochemical foundation of learning and memory. And we found that BDNF, which is a neurotrophin associated with synaptic plasticity and neuron survival, was reduced in both a VCD and genotype dependent manner. Similarly, central signaling synaptic plasticity related molecules were activated or weren't activated as much in a genotype and VCD dependent manner. And that included AKT1, phospho-mTOR, phospho-ERK. And further downstream targets, including CREB1, ATF4, and EPHB2, were similarly reduced in a VCD genotype-dependent manner. Now, the EPHB2 is particularly interesting because this is associated with proper functioning of the NMDA receptors. And so this is probably resulting in misfunctioning of NMDA receptors. So to overview this in a more visual manner, the VCD menopause mimic reduced DHA status in both the ApoE3 and ApoE4 mice and led to a reduction in BDNF, particularly in ApoE4 animals, but also ApoE3 to some extent. We saw that the ApoE4 and VCD combination reduced central synaptic plasticity related pathways, including mTOR, ERK, and AKT, which would then further downregulate BDNF. And overall would potentially lead to less neurogenesis, less synaptic survival, and the reduction in synaptic strength. So we wondered whether DHA supplementation may restore this levels of BDNF and synaptic plasticity, and also ameliorate some of the deficits in cognition. And that's kind of what we found. So we found that DHA levels in the brain increased in response to DHA supplementation at 2 grams per day. We found that object recognition memory was restored in the ApoE4 animals. We saw a trend towards an increase in some of the spatial memory tasks, but this wasn't associated with the VCD mimic. And to explain this effect, we also found increases in BDNF and phospho-AKT in the brain. So to conclude, ApoE4 leads to deficits in spatial memory. The menopause mimic, VCD, leads to lower recognition in ApoE4 mice. Treatment with VCD treatment reduces levels of DHA in the brain of both ApoE3 and ApoE4 mice. And supplementation can restore DHA to some extent and mitigate the impact potentially by the BDNF AKT pathway. The final take-home message I'd like to mention is ApoE4 females represent 13% of the UK population, and so are a subgroup that would particularly benefit from some sort of therapeutic intervention, perhaps higher intakes of DHA. I'd like to say thank you for listening, and a big thank you to all these people who helped me throughout all this research.
Great. Thanks for that, Matthew. Excellent stuff. Do you want to stop sharing, and then we can, as much as anything, actually it helps me so I can see who's got their hands up. We've got, first of all, Sue Fairweather Tate, really nice, easy question to get going. What's the definition or age of early versus late onset Alzheimer's?
So I believe it's anything over 40 is, under 40 is referred to as early onset.
Okay. And then Michael Muller said how good the talk is. And then Jeremy Turner asks what VCD is, and were the estrogen levels checked in these mice to confirm menopausal status?
So VCD is a chemical that leads to the breakdown of the follicles, particularly in the ovaries, without damaging the actual ovaries. So you actually get a very similar profile as seen in human menopause, rather than the classical system that goes through with mice. Sorry, I've just lost my train of thought. What was the other part of the question?
Well, were the estrogen levels actually checked?
Estrogen levels weren't checked, but we did FSH instead, because from our literature, it turned out that FSH was a better marker of this, and we did see that through the VCD injections, we get a massive increase in FSH in only the VCD injected animals.
Okay, thanks. So we've got a couple of hands up. So Charles French Constant.
Yeah, thank you very much for a very nicely crafted talk. That was lovely. 2 questions. An easy one first. Did you look at neurogenesis in the DHA supplemented animals, hippocampal neurogenesis?
No, we've not looked properly into neurogenesis, but I guess BDNF to some extent is a marker, but not
no.
but no.
It would be really easy to look.
Yeah.
And be good. The other thing, a more general question, can you give me any sense, based on your data and the prior literature, what the relative effect size would be of DHA compared to HRT in ApoE4 postmenopausal women?
I'm not sure. I don't think this has been looked at all. I think this is it's like a very new area. Really hasn't been researched, so I can't really give a figure onto what sort of difference there would be between HRT and.
But based on your data, what do you think?
So I mean, well, in the mouse or the rodent study, we didn't actually look at HRT. So I think that's something we would need to look at, whether we could actually give the animals estrogen, and then you'd have a clear answer of which one works best in mice. But in terms of human studies, I don't think there's really that much in terms of looking at this in specific population of menopausal females.
Okay, thank you.
Okay, thanks. And then Teresa Foster's also hand up. Teresa.
Thanks, Andy. Yeah, really interesting talk, Matthew. Just to say that the East of England Ambulance we've just received funding to initiate a national study about the impact of the menopause transition on female ambulance staff. So, yeah, with a view to, it's some exploratory work to start off with, and then with a view to perhaps doing some sort of interventional work, you know, a bit further down the line. So, really fascinated, and I wondered whether you could share the link to your paper, please.
Yeah, no problem. Yeah, I can do that, absolutely.
Thank you.
If you could stick that, maybe Matthew, in the chat, that would be
sure.
Cool. Stephanie's just asked if there's any confounding effects of mercury and heavy metals found in oily fish.
I'm not. I obviously I do know about there being a link to this, but I'm not entirely sure. I don't want to give you the wrong information. I don't know enough about the mercury side of things.
Okay. And I've got one last question just to finish us off, which is really about what's the public health implications of this, because we kind of know fish oil is good for you. So
yeah.
So
well,
what should we do as public health people?
I think from my perspective, like looking at all the literature, I think there's a lot of support for having fish or oily fish as one. I'm not sure the data is quite there in terms of having fish oil supplements yet, but I think, you know, from the randomized control trials, which don't show as good of an effect compared to the epidemiological cohort studies, I think this work sort of shows that it's about finding the people who have reduced levels of DHA in the brain or who need the intervention to sort of supplement or get those people to have the oily fish to sort of improve their outlook towards AD.
I just wonder though, given that obviously there are, if you have too much oily fish, there are a few negative things, aren't there? But in general, it's relatively low risk.
Yeah, I think that's the thing. It is relatively low risk, especially if you're taking it through having oily fish once a week.
Yeah,
it's quite a small step, really. Obviously, you have a sustainability issue on that side, but to some extent.
I could make a comment.
Yes.
Just to say that there has been quite a lot of work done on mercury contamination and others in relation to oily fish, and there are obviously high correlations. But and in pregnant women, there is, you know, the suggestion is that they don't have more than one in this country, don't have more than one portion a week, 2 portions a week due to that reason. But there's been quite a lot of work done, and I can send you the details by looking at oily fish consumption and childhood development, and there doesn't seem to be an issue with that. The benefits of the omega-3 seem to be more protective than any effects of the contamination.
That's brilliant. Yeah, if you could send them through. Sorry, I don't know enough about that.
Great. Okay, thank you. And there's a couple of helpful comments from Ailsa and Sue Fairweather-Tate in the chat as well there. I think we need to move on now to our final presenter. So we've got Jeremy Turner, who's a consultant physician at the Norfolk Norwich University Hospital, also honorary professor in Norwich Medical School. And Jeremy's going to be talking about the Clinical Research Network East and how it might be able to support the work of NIHA. So over to you, Jeremy.
Thank you, Andy, and thanks, Anne-Marie, everyone, for the invite to come and speak. So just struggling to share my screen. Ah, that's better. Is that at full size?
Yeah, perfect.
Can you see that? Lovely,
Perfect.
thank you. So I'm going to give just this little 10-minute summary of what the Clinical Research Network, and particularly the CRN Eastern, is. And I am one of 2 clinical directors of CRN Eastern. So I thought that I would, I'm aware that there will be varying levels of background knowledge in the room, but I thought I'd start right at the basics first, if I may. So the beginner's guide to the NIHR CRN is that the NIHR has a budget of a little over £1 billion a year. The CRN is part of the NIHR and consumes slightly over 300 million of that billion annually. The Clinical Research Network, sorry, I should have defined, CRN is Clinical Research Network, obviously. Coordinating Centre is hosted by the University of Leeds, and the CRN is an England national piece of clinical research infrastructure that covers all regions of England, but not the devolved nations. And it's divided into 15 local clinical research networks, or LCRNs. And obviously CRN Eastern is one of these 15. So the current arrangement has been standing since 2014, and it took over from a previous slightly less uniform landscape of clinical research networks, which included topic-specific networks and also the very confusingly named CLRNs. So this is an absolute minefield for anyone who suffers from a bit of mild dyslexia like I do. The CLRNs were the comprehensive local research networks, but they are now consigned to history. One of the basic underpinning principles of this whole system is it's all about the portfolio. If the study is on the portfolio, it is eligible for clinical research network support for recruitment and delivery of the study. If it's not on the portfolio, it is not eligible for CRN support. And the portfolio is divided into a commercial part and a non-commercial part, with the former obviously funded and sponsored by pharma. The entire NIHR, it uses this best research for best health, nattily known as the BR4BH strategy document, to underpin all its work and its thinking. And there has just been a refresh of the best research for best health document in this year, 2021. And these are the 7 strategic areas of focus for the entire NIHR, obviously including the CRN, in BR4BH. And I think some of these 7 points are particularly relevant potentially to NIHA. The first one, obviously topically, is build on lessons learned from the response to the pandemic. The second one is build capacity and capability in preventative public health and social care research. I see that as particularly NIHA relevant. Improve the lives of people with multiple long-term conditions through research. Again, I see that as particularly relevant. Bring clinical and applied research to underserved regions and communities with major health needs. And I see that as potentially particularly relevant, and would encourage you all to consider reference to these 3 particular strategies or parts of the strategy in BR4BH in grant applications, funding applications, etc. Others for reference are embed equality, diversity and inclusion across the NIHR's research, systems and culture, strengthen careers for research delivery staff and underrepresented disciplines and specialisms, and expand our work with the life sciences industry. So there is this constant focus on the relationships with pharma because of the obvious impact that will have on GDP. So getting specifically closer to home, CRN Eastern, the headlines. So the host organisation is the Norfolk and Norwich University Hospital Foundation Trust. In CRN Eastern, we have approximately £20 million a year annual budget. What we do with that, I will come back to shortly. Our footprint covers a nearly 4 million head of population. And last year, 2021, we recruited over 120,000 people, residents of the East of England region, to NIHR portfolio studies. So this is approximately 3% of the entire East of England population went through portfolio studies last year. So obviously this is a vast amount of recruitment activity. Approximately half of that was to the urgent public health studies. So these are the pandemic related studies, the vaccine studies and others. We're generally perceived as a high performing local clinical research network, and particular areas of strength are industry performance, patient and public engagement, primary care recruitment, and performance of many of our specialty groups are amongst the national leading LCRNs. So how does it work? Well, about £20 million is distributed through our partner organisations, which are mainly NHS acute trusts, primary care practices and others. And by funding research nurses, clinical trial practitioners, admin and clerical staff and others, we enable and support the delivery of portfolio studies to complete on time and on target. The vast majority of our funding goes on funding salaries, so research delivery staff salaries. Obviously, we need to be cognizant of where we sit in the NIHR family of infrastructure. So in this little schema here, we've got a hypothetical timeline of a biomedical innovation from invention through evaluation and into adoption. The little red bar here shows where the work of the clinical research network sits. So largely in the evaluation phase of an innovation, but also for reference, you can see where we sit against other parts of NIHR infrastructure in the region and nationally. So the BRCs, the CRFs, the experimental cancer medicine centres, etc. So that's really just a sort of conceptual diagram. These are the 30 clinical specialties. I won't trawl through them in tedious detail, but of particular relevance here, obviously age and aging, as it used to be called, now just shortened to aging, has its own specialty. This is the region. So we cover the whole of Norfolk, the whole of Suffolk, a large chunk of North Essex, part of Hertfordshire, Cambridgeshire and Bedfordshire. And this map shows the 16 acute NHS trusts that are part of CRN Eastern. We also recruit through approximately 3 out of every 4 GP practices across the region. That's the highest recruitment rate for GP practices nationally. Number of other NHS providers, such as the community trusts, and now, as of the last 12, 18 months or so, also non-hospital settings. So we now have a new part of our remit, which is to extend our research activities into prisons, schools, care homes, pharmacies, and other non-traditional NHS settings, because of course there is so much research, particularly social care, public health research that can be done in these settings. And again, I see that as a particularly relevant development with reference to the work of NIHA. We have a range of public engagement services, including Be Part of Research and the Joint Dementia research, where people can pre-register their potential interest in future suitable studies. And these are just 2 examples. So last year, for example, there was also the vaccine registry, where people were able to pre-register their willingness to be approached for involvement in a COVID vaccine study. And indeed, we ran a COVID vaccine study in Norwich, and recruitment was fortunately remarkably straightforward. We recruited over 500 people to the vaccine study in Norwich, and it was relatively easy to simply phone up people who had pre-registered their desire to be part of a vaccine study. And indeed, you know, the demand to be involved in that study way outstripped our capacity, unfortunately, to enroll people. But that's a nice problem to have had from a researcher's perspective. This slide is purely for reference, but there's a range of other sources of information about CRN Eastern. I won't tediously attempt to play the little YouTube video now, but it is only 3 and a bit minutes long. It's worth watching. It certainly put a smile on my face when I watched it. And just briefly to finish, an example of a case study, so a study that we have supported in the recent past. This is the BEST 3 study, which is the Barrett's esophagus trial. And this was run out of CUH and in a number of primary care settings in the, CUH is Cambridge University Hospital, so Addenbrooke's, and in a number of primary care settings in Cambridge. It's a fascinating little device. The participant in the study, or the patient as will be, now that this is being rolled out into routine practice, swallows a capsule with a gelatin coating. It looks no different from any other medicine capsule, apart from the fact that it's attached to a thread like a bit of dental floss, and you swallow it, and in the acidic environment in the stomach, the capsule disintegrates and this hydrophilic sponge is released, which expands. And once you've had it down in your stomach and you're holding onto the other end of the bit of string, once you've had it down in your stomach for a couple of minutes, you then pull it back, which must be a slightly weird experience, until you expel the expanded sponge from your mouth, and then put it into a specimen pot and label it up and send it off. And on the way back up through the esophagus, it picks up cells from the esophageal lining, and these can then be analysed in a cytology laboratory looking for the pre-malignant changes, because Barrett's esophagus is an esophageal cancer, pre-cancerous stage. And this work was led by Rebecca Fitzgerald at Addenbrooke's Hospital, and there she is being interviewed on ITV, on the television news, about the BEST 3 study. And here is a lovely quote from a participant in the study who said that she believed that this trial had saved her life. And that really is my conclusion, because that in actual fact is what we're all about. We're about maximizing the number of people in our region who can come through NIHR portfolio studies and experience the benefits to their health that being a study participant confers. Thanks, and I hope that made a little bit of sense, and I'd be delighted to take any questions.
That's great. Thanks, Jeremy. It made a lot of sense. It kind of reminds me that BEST 3 study of fishing for crabs, as a child on the Norfolk coast, sort of lowering this thing down and wondering what's going to come up. So yeah, really, really interesting. I'm just looking in the chat. There's no questions in the chat. Just check if there's any hands up. Not at the moment. I've just got one thing actually, which I was really interested in, which is, basically expanding to these other settings, which of course is fantastic, but must bring considerable challenge. And I wonder,
absolutely.
I mean, just thinking out of my own personal experience, working in schools, often there's schools have other priorities, but there's also can be research fatigue. And I wonder if you've had any experience so far as to, how well that might work.
No, I think you've hit on a really central point of this for us, Andy. Our whole history, our whole culture is steeped in the NHS. The NIHR grew out of the NHS. We only recently dropped the blue and white NHS logo from all our branding, and moving into these non-NHS settings is and will continue to prove a major challenge to us operationally, because we're just not used to working in these settings. And although we're being encouraged very strongly to pick up the rate of portfolio recruitment in these non-NHS settings as fast as we can, in actual fact, the stats from last year, that was one of the less bright points in our performance from last year. Now, of course, last year we had the excuse, so to speak, of the pandemic pressures, but those have largely abated now, and it's going to be very interesting. So far we've delivered studies in care home settings and in hospice settings albeit relatively low numbers, and we're continuing to learn. Certainly historically in Cambridge, studies have been delivered in schools, but you're quite right, it's going to be difficult, but important. And I see this as I've already said, as particularly relevant to the future work of NIHA.
Absolutely.
You know, and the reason, one reason I think why I'm presenting today is that I'm very keen to support NIHA with the infrastructure of CRN Eastern. I think that what NIHA is doing is hugely important for the health and well-being of people living in the east of England and further afield. And I think that CRN Eastern can support NIHA activities in a very important and meaningful way, but we need to work closely together. And obviously an important part of that is understanding one another's work.
Absolutely. Okay, thanks. That's great. Anne-Marie's got a hand up.
Yeah, thanks a lot, Jeremy. I wonder, would you just take a minute just to talk us through process? You know, when should we get involved with CRN Eastern when we're planning our trials, and also kind of the range of services you can provide?
So thanks, Anne-Marie. The answer to the first part is as early as possible, because even at application stage or pre-application stage, if you can say that you have worked with us and engaged with us, this will be another box ticked, especially for NIHR funded funding streams. But more generally, you know, all the major funders will either want to see or will be pleased to see that you have engaged with the local clinical research network, so that you know, we're already working together and planning and considering the practicalities of how participants will be recruited, in what settings, and so on. In terms of what support can be offered, it is predominantly research staff. So that's research nurses, clinical trial practitioners, receptionists, admin and clerical, and other support. And in actual fact, these people can take a huge amount of the recruitment burden off of the CI's team. So any study where the design involves recruiting participants, we can potentially take most or all of that off your hands. And, you know, to some extent, you can then get on with other more important, more sort of high demand academic and intellectual activities, whilst the shop floor is recruiting people, you know, taking them through the inclusion, exclusion, signing the consent forms, doing all the study paperwork, maintaining the files, arranging the follow-up visits, and so on and so on and so on.
Yeah, thanks, Jeremy. I think we've used your services in the past, and I think people don't fully appreciate the range of services you can provide till you actually ask the question.
Absolutely, it's a really central question, Anne-Marie. And as successful as the CRN has been, and indeed, you know, last year nationally recruited over 1 million people to portfolio studies. I mean, it's unbelievable performance. I still think that we've been, frankly, not very good, and that's putting it politely, at promoting ourselves. And I still think that we have under-realized our potential, both, you know, regionally and nationally, if I was brutally honest.
Okay, thank you. So, yeah, no, sorry, carry on, Jeremy.
Well, I was just going to say, we haven't done enough of this sort of activity.
Yeah, no. Good that
Sorry,
you're doing
Andy.
it. No, it's fine. It's good that you're doing it now. Just we've got 2 minutes remaining. Ailsa's got a hand up.
Yes, hi Jeremy. Just a
Hi,
quick
Ailsa.
Hi, how are you doing? Sorry, I can't see you. I've got problems with my camera, my revised laptop, and so on.
Oh, bad luck. I can hear you.
Yeah, so there's kind of two things. One was so basically for the portfolio, as I recall it, we used to have very standard funding agencies, and the NIHA is one of them. So actually to get portfolio help. The second one is really, and I think that probably still stands. I guess the question is, how would the support be for more community settings? Because I can see, I remember the sort of clinical, and I don't quite know how that could be arranged and how that would work.
So you're dead right about portfolio eligibility. That's not really changed. So it needs to be one of the major public sector funders, such as NIHR, MRC, BHF, Wellcome, etc., or it needs to be a commercial sponsor. Although even then, there is some scrutiny and quality control. For delivery in the non-NHS settings, we are in the process of growing a whole separate delivery workforce. And this gets back to Andy's earlier question and my earlier answer. We're steeped in the culture and the history of the NHS. We're quite happy having colleagues in dark blue uniforms in NHS settings doing the work, but having people wearing their own clothes and driving around the patch in their cars and turning up at schools and prisons and care homes, but doing the same job is a step into the unknown for us. But it is starting to happen, and that's how it's happening.
Okay. Oh, thanks, Jeremy. That's helpful. Yes, it's useful to know. Thank you.
And then just a really quick question from Sherry. She's asked, she said, well, historically CRN research nurses weren't able to undertake research interviews, administer instruments, etc. Are they able to do so now?
Sorry, say that again. I'm just reading
it. Historically, CRN research nurses weren't able to undertake. Are they able to now?
Yes, they are. And so particularly, for example, with when you say administer instruments, you mean like medical devices, or you mean like
questionnaires?
Questionnaires, yeah, fine. Okay, so one example where this now very much is the case is dementia studies and rating questionnaires, and rater training is now a really big thing for us, and there are lots of rater trained colleagues who can administer these questionnaires. So yeah, we've perhaps slowly but finally moved with the times a bit on that one, if I'm understanding that question. Yeah, great. Thank you.
Okay, well, I think that's all we've got time for. That's really excellent. Thanks so much, Jeremy. Really useful to hear that.
Thanks, Andy.
So thanks to all the speakers today. We've had 3 really interesting presentations and some really great discussion around them as well. Just to flag up the next NIHA seminar, which is on Friday the 3rd of September. And the focus of that is on musculoskeletal health. And the keynote speaker is going to be Professor Malcolm Jackson from the University of Liverpool, who's former lead of the Institute of Aging and Chronic Disease. And hopefully you should all have that already in your diary. So that's something to look forward to in September. So I think without further ado, she'll close this session today. Thanks once again, and enjoy the rest of your days, everybody.